Bismillahirrahmanirrahim. We will discuss today injuries around the elbow. We will talk about one of the most important fractures encountered in children, which is supracondylar fracture of the humerus. Supracondylar fracture of the humerus is the most common fracture in children as regards the incidence and as regards the complications. Why supracondylar fracture is important? Because it can lead to miserable complications, ischemia of the limb, loss of the function of the limb. Mechanism of trauma, either direct trauma or indirect trauma. Indirect trauma is the most common. Falling on the outstretched hand with the elbow extended can lead to supracondylar fracture of the humerus. Direct trauma by falling on the elbow joint. Classification of supracondylar fracture of the humerus. It can be classified according to the displacement of the distal fragment. Usually in orthopedic trauma, we refer to displacement by displacement of the distal fragment. Two types. Extension type, the distal fragment is displaced posteriorly. We can call it posterior type. Flexion type, the distal fragment is displaced anteriorly. Which is more common? The extension type. More than 90% of supracondylar fracture of the humerus is extension type supracondylar fracture. Classification according to the degree of displacement. Why this classification is important? Because it gives us an idea about the severity of trauma and also gives us an idea about the line of treatment which will be used. Grade 1, undisplaced fracture. Grade 2, partial displacement. Still, there is some contact between the proximal and distal fragments. Grade 3, complete displacement of the two fragments. Complications of supracondylar fracture of the humerus. Why this fracture is important? Because it can lead to vascular injury, can lead to nerve injury, can lead to stiffness of the elbow, malunion, myositis ossificans. When you are confronted with a case of supracondylar fracture of the humerus, how can you diagnose vascular injury? What are the signs of acute ischemia? 5 B's. You should feel the radial pulsation. If there is no pulsation, query vascular injury. It is not sure. The pulse is unreliable to diagnose vascular insult. Pallor, pain, paralysis, paresthesia. What about pain? How can you differentiate between the fracture pain and ischemic pain? Fracture pain is relieved by immobilization and proper analgesia, while vascular pain is severe, intolerable pain, not relieved by ordinary analgesia and not relieved by splinting of the limb, and also associated with other manifestations of ischemia. What is the most important sign to diagnose ischemia in a case of supracondylar fracture injury? Pulsation, capillary circulation. Sluggish capillary circulation of the nail bed is the surest method to diagnose vascular insult. It is a simple test, an objective test. You do it by yourself, while the other 5 B's unreliable. The patient always crying because there is severe pain. Paralysis, sometimes you can't assess the motion because the child is in severe pain. Paresthesia is subjective. Also the pulse, sometimes you feel the pulse and the circulation is impaired. So the shortest method to assess the peripheral circulation is the capillary circulation. Sluggish capillary circulation denoting vascular insult. What is the critical time for interference? You should diagnose vascular insult as early as possible to save the function of the limb. If you delayed in the diagnosis, irreversible damage of the muscles and the nerves can happen. So 6 to 8 hours is very important. Why this subject is very important? Because vascular insult can lead to acute ischemia. Your task as a general practitioner in the outpatient clinic, when you diagnose a case of supracondylar fracture of humerus, you should register the state of circulation. If the circulation is good, that's okay. If the circulation is not good, what is the first line management for a case of impaired circulation? Number one, if the patient is confronted to you with ischemia and the patient has tight bandage or tight cast, I should relieve the tight cast. If the patient is presented to you without casting, I can do some manipulation of the fracture and I will splint the limb in the position in which the circulation is good. This is the first aid management you should do for a case of ischemia. Also, you should register the time of trauma and the time passed since the trauma, because it is a critical time. If there is vascular insult, what are the methods to be sure of the ischemia? I should refer the patient either to orthopedic surgeon with vascular skills, microvascular skills, or I refer the patient, I'll ask the vascular surgeon to help me in the management of this case. Doppler ultrasonic evaluation is non-invasive method for diagnosing impaired circulation of the limb. If there is vascular insult, I'm sure about this, I can do immediate surgery, brachial artery exploration. If the artery is spastic, I can give intra-arterial injection of saline and barberine to have vasodilation of the artery. I can do desheathing to achieve local sympathectomy. If the circulation is good, that's okay. I will fix the fracture and the situation will be well. If the artery is contused or there is a spastic part not relieved by injection of saline or barberine or desheathing, I will do resection of the spastic part or the contused part, and I will do saphenous vein bypass graft. I should fix the fracture to help to preserve my repair, because if you do manipulation after repairing the artery, you can disrupt your repair. What about nerve injury? What is the most common type of nerve injury in supracondylar fracture of the humerus? What are the nerves related to the supracondylar fracture? This is a question for the audience. The most common nerve to be injured after supracondylar fracture of the humerus is the anterior interosseous branch of the median nerve. How can you diagnose this anterior interosseous nerve injury? Pointing index. You ask the patient to grasp his hand. If the index is pointed, this means that the flexor digitorum profundus with index finger is paralyzed, and this is an indication of anterior interosseous nerve injury. Radial nerve injury, wrist drop. This is second common type to be injured. Second common nerve to be injured. Ulnar nerve injury, loss of adduction, or positive card test. Ask the patient to hold a card between his fingers. If the patient is unable to hold the card, this is a positive card test due to paralysis of the interossei muscle, which are innervated by the ulnar nerve. What is the common type of nerve injury in supracondylar fracture injuries? Neuropraxia or actinotemesis or neurotemesis? Do you know neuropraxia? Neuropraxia is a concussion of the nerve. Actinotemesis is injury of the neurolemmal sheaths with preservation of the endoneuria. Neurotemesis is complete cut of the nerve. Fortunately, the most common type of nerve injury is actinotemesis. Even in ischemia cases, actinotemesis. and usually recovery takes some time for recovery of the nerve. How can you treat supracondylar fracture of the humerus? Undisplaced fractures, you can just immobilize the patient with posterior back slab of Paris, cast of Paris slab for 3 weeks. Only for 3 weeks. More than 3 weeks can lead to stiffness. In displaced fractures, I can do closed reduction and external immobilization for the elbow with back slab also. If the reduction is not attained, I can do closed reduction and percutaneous spinning using smooth spins. Smooth spins. If I did several trials for closed reduction and the reduction is not attained, I can do open reduction and pinning also. Example for supracondylar fracture of the humerus, we can see lateral film of the elbow joint in a child. The epiphysis still open, extension type, grade 3, fixation, closed reduction, and fixation with smooth pins. What is the ideal method of fixation? The ideal method is one lateral and one medial pin. Smooth pins, not serrated pins, not screws. Serrated pins can lead to physical injury. Smooth pins for 3 weeks only, not more than 3 weeks. One medial and one lateral is the preferred method of fixation to achieve rotational and transitional stability. Some authors or some surgeons put 2 lateral pins. 2 lateral pins insufficient because it can't prevent rotation. More than 2 pins, adding more trauma to the physis is not preferred. But in some cases, you can add 1 pin if the stability of the fracture is not attained by 2 pins. What are the indications of open reduction? If I have open fractures, I will do debridement of the fracture and I will fix the fracture because it is already open. Failure of closed reduction. If I am a junior staff and tried closed reduction once and I failed, I can ask my senior staff to achieve reduction if he failed. No need for several manipulations because this can lead to muscle injury and can lead to stiffness and myositis ossificans. So 2 or 3 trials of reduction is sufficient. Sometimes soft tissue interposition, sometimes the fracture is highly unstable, so open reduction is the last method of treatment. Or fractures associated with vascular injury. Actually, you will do exploration. While you are doing exploration, you should fix the fracture to protect your vascular repair. The second title and the second most common fracture around the elbow is fracture of the lateral humeral condyle, also in children. This is a case of fracture lateral humeral condyle. Only I give you some X-rays only, not in details. This is intra-articular fracture. If not united, it can lead to cubitus valgus, deformity around the elbow, and the ulnar nerve affection. The best method for treatment is open reduction and internal fixation using smooth pins, smooth key wires. Why open? Because it is an intra-articular fracture. I should achieve anatomical reduction and also achieve accurate reduction and stable reduction. You should do it open. Sometimes if it is in position, I can do percutaneous pinning. Another case of lateral humeral condyle displaced laterally, you can see fixation, open fixation, and the fracture is united in a good way. The third title is fracture around the elbow. In fractures around the elbow is fracture olecranon. This is a lateral film of the elbow joint in adult showing fracture of the olecranon. Why this fracture is displaced? Because the olecranon is attached to the triceps tendon and it is an intra-articular fracture. Intra-articular fracture equal anatomic fixation to prevent osteoarthritis. And to achieve union, you should achieve stable reduction. One of the most preferred method, or the method of choice is fixation with tension band wire. Tension band is a dynamic method of fixation, allowing compression of the fracture while in motion This is the preferred method. It should be done open reduction, not closed, and using key wires and circulage wire to achieve fixation. This is another case of fracture occurring, comminuted fracture. You can't apply the principle of tension band wiring in this case. I can give both a plating, contour the plating for the fracture occurring or hook plate. The other title is just the X-rays only, and fracture of the head and the neck of the radius. Fracture neck is common in children. Fracture head of the radius is common in adults. Fracture head can be just sectorial fracture, undisplaced, or partial displacement, or comminuted, sometimes associated with dislocation of the elbow. This is a case of epiphyseal of the elbow joint showing a fracture of the head of the radius in adult. The physis is closed. This is a case of fracture head radius fixed with mini plate to achieve articular congruity of the joint. There's another case. It is a fracture in adult, epiphyseal and lateral film in adult, showing intra-articular fracture and supracondylar fracture. It is called intercondylar fracture. It has to be both two elements, supracondylar element and intra-articular element. The management of this case is open reduction and internal fixation. You should achieve also anatomic reduction of the fracture and restoration of the joint congruity to prevent osteoarthritis. No way for conservative treatment in such case. Dislocation elbow in children and in adults. In children, the most common is pure posterior dislocation. The same complications as supracondylar fracture of the humerus. And the management is simple, usually conservative treatment. Just close the reduction by traction, inflection, and putting the elbow in flexion more than 90 degrees. And you should also take care about the vascular insult and nerve injury. This is a case of dislocation of the elbow in adult, lateral film and the epiphyseal, posterior dislocation. Posterior dislocation of the elbow is very common. It can be either pure dislocation, no associated fractures, or associated with other fractures like fracture head of the radius. Here we can see fracture of the head of the radius. Can be associated with fracture of coronoid process of the ulna. So it is an urgency. It is an emergency. You should achieve closed reduction first and then reassess the elbow joint.